Hello, this is Dr. Thiele, and this is our topic lecture for the September-October PF topic, Medicare for All. So the exact topic wording is the United States federal government should enact the Medicare-For-All Act of 2019. This comes directly from the NSDA website. Some cool things about this topic is it has a very specific plan, as you saw. It references the specific bill to pass, or at least one of two bills to pass. And so it makes it a lot more narrow debates than some of the other topics you might be more used to that are, you don't know exactly what the plan is doing because it's just an amalgam of lots of people's proposals. It's also very relevant, as you can imagine. You can see healthcare is something that, in society of the pandemic we are living in, is something that is on the table to be discussed. Where would universal healthcare put us in our society? Would we have better preventative measure? Would we have a better reaction to what's going on with COVID? All that's very, very important. So that's something that is super, super relevant. There's also a lot of literature and studies. So there are, if you just do single payer, if you start with healthcare, thousands and thousands of studies. If you even narrow that to like single payer system, which is a type of healthcare reform that's been advocated, you still have hundreds of thousands of studies. And Medicare for All is only a specific type of the single payer system that has been promoted. So there are a lot of studies out there, and you can search for your, forever and never forget it all. And so it's important to kind of identify the right studies and to focus on those for the key issues. Next, it's also very partisan. As you can see, Bernie rallied on this for when he was running, and it's something that a lot of people in Washington believe heavily in, and a lot of people in society believe heavily in. And so it's something that there's also people that believe very against it as well, that think the government has no role in healthcare. And so you have very partisan debates which can go back and forth. Also, there are many contentions. It's not just one topic with one real contention everyone talks about. There are probably at least 3 or 4 big contentions, and then there's probably another dozen to a dozen and a half, more extra contentions that could be read rarely if you want to throw someone off guard or if they want to throw you off guard. So let's talk about the basics of healthcare, just to give you a quick overview before we start about the topic. Right now in the United States, if you want health care, this is kind of your bracket you could be in. If you're over a certain age, you get Medicare right now, which, as it says, covers hospitals, physicians, prescription drugs, doesn't really cover dental, and has some sort of premiums on top of that. Also, if you have low income, you can get Medicaid, which is a similar type program than Medicare, but geared toward people. You can also get CHIP with low income. There's also the individual market, which is if you want to go out right now and just buy your own insurance, you can. Maybe you can get a little bit of subsidies from the government to help offset that, or you group in a group of people, you get a rate in your group by pulling together. But for the most part, you are in charge of that. Employer sponsored is where if you're working full time for a company, or if they were nice to you and you're not working full time, they will give you health care, which means they will cover at least a portion of what you would be having to buy in the individual market. And so the advantage of this is it could be a little bit more pooled within the employer. They can make sure that everyone's getting good health because a healthy employee is a productive employee. And so there's sort of a win-win on both sides. Finally, you can have no health care. If you're uninsured, you just go to the hospital, and if you get really sick, you pay them everything out of your bank account, and once you're out of your bank account, you go bankrupt, and then the government kind of covers the rest. And so this is kind of the option of how it's split right now. As you can see, most people are in employer-sponsored healthcare. But it's not everyone, and there are many people that fall through the cracks that either have to buy it their own because their employer healthcare isn't good or just isn't provided to the degree they want, or they just have to buy it their own because they're not full-time and they don't get it. Alternatively, they're uninsured, so their employment is they just don't buy it at all. They rather go uninsured and just take the risk. And so there are different people in different degrees are getting health care, in fact, getting even Medicare if you're over 65 right now or disabled. And this is something that the plan would try to expand that coverage to universally to everyone. How does healthcare work? So right now, privately, what happens is you have 3 basic parts. You have a deductible, you have a co-insurance, and you have out-of-pocket. So you go to the doctor and they say they have to do some surgery or something on you. It's going to cost this amount. Up to that first deductible, which could be $500, $1,000, whatever, you are paying that full amount. Once you hit that full amount on the deductible, Then you move into a co-insurance model. So if it costs less than the deductible, you're paying 100% of it. If it's more than the deductible, you pay the first $1,500, and say it costs $2,000 for that extra $500, you're paying a certain percentage of that $500. So if co-insurance was set at 20% and it was $500 you were paying, then that means the insurance company would cover 80% of that, and you would ultimately be covering $100 of those $500. And then once you get to a total limit, say you hit that limit, it could be 15,000, 5,000, 20,000, whatever. You hit that overall limit that you have paid out of pocket. That out of that 20% co-insurance keeps adding up. Once you hit that limit, they say, okay, you've paid enough. We will pay everything else. And so generally you should think of it as there are 3 tiers. For very minor stuff, you are paying. Middle of the stuff, you might be paying a small percentage. And for things that are really, 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 really big, at a certain play, you just pay a fixed amount, and everything after that they will cover. So that only assumes if they're covering it, if it's something that is covered by the plan and you are in network. If you go out of network or it's not necessarily covered by the plan, then what was shown above might not apply. It might be a different scale. It might be no scale, and just say you're paying a lot out of network. And so common things out of network that happen are mental health care, for example, psychiatric services. Alternatively, ambulances. Sometimes emergency care is or is not covered depending upon how you used it and when you use it. And so, you could take an ambulance thinking, I need to go, it's an emergency. It turns out not to be an approved emergency, and you're paying, $10,000, $15,000 just for a trip, down the road to a hospital. And so, something very important, as well for cost as well. And this is the median amount that an employer would end up paying. These are just things that are out of network procedures, and don't worry too much about the money. Just think about, because if the employer is paying that amount, imagine what the individual person is paying. And so that's going through it. And so all these things can kind of add up. You could just have your own type of doctor you like, but they're not a network. They don't work for the company. And so you don't get them. And if you want to go to that doctor, you have to pay more. Medical costs are definitely increasing over time. And so if everything was fixed or taken care of, or a well-functioning system, it would be great. But the system is not very well functioning. And the costs have been increasing over time, greater than the inflation rate. And so it's such that it outpaces and it's going more than it should be. More of your income is going to medical the older we get as a society. And so as you can see, the numbers kind of growing up per person per year that you're spending on medical costs. Now it's an average, so if you're very young, it might be very little, but if you're very old, it could be 3 or 4 times that per year. And so it's something to think about, that not only as you age do you spend more, but even society generally is spending more each and every year, and it's outpacing the amount it should cost. Now, you would think, okay, well, we're spending more. Maybe that's just what's happening in society or happening in the world. Things are getting better. People are living more. Well, when you look at the world, it's not exactly like that. The U.S. spends way more as a percentage share of GDP, meaning our country's economy. We spend way more than all the other countries. And that includes mostly European countries that have higher standards of care than us in a lot of places. And so what you should think about is we are paying more for less in a large majority of services in healthcare. And some of that is just cost overrun. They might charge you a lot more for a certain thing just to go through all the safety measures, regulations, or more importantly, they got to charge you a bunch more. So when they take the percentage out and then a deal they have with the insurance company, they pay a fraction, actually, the insurance company, and it's only people that are uninsured pay a lot more. And then if you're bankrupt, you go to bankruptcy, and then a lot of it gets wiped. And so if they can't collect on someone who goes to an emergency room, has a heart attack, they spend all this money to try to save them, that person dies, has no money. It's not like they can't just say, doctor, we can't pay you, company that made the heart stuff, we can't pay you. No, they still pay them. They just end up having to raise costs to everyone else. And so that's a portion of the cost increase, but it's other things as well that cause the cost increase that have nothing to do with that. And so generally the way you should think about it is our costs are rising and they're way higher than they should be, and that's pretty much a universal fact. Even if the costs weren't rising, even if most people could get it, what about the people that can't get it? What about the people that don't have insurance? And so if you don't have insurance, primarily the reason why is it's too expensive, and you put yourself at a lot of risks. You might be less likely to get a checkup. And because you're not getting a checkup, every year, something that could be small, could have been noticed, could have been fixed for very cheap preventatively, gets worse and worse and worse and worse and worse, and then bam, you have a big heart attack or some sort of injury, and you have to spend a lot of money on surgery to fix yourself when you could have spent a little money 10 years ago and fixed the problem. And so there are huge effects, and they affect in all sorts of people distributionally who do not have access to healthcare right now, or have an a plan that is not well equipped. So with this, there must be solutions, right? So single payer is a popular solution. You can see over time it's been proposed by various people as sponsors signing up into bills. One or two or three bills per session, or sometimes there's just one and a lot of sponsors. And so this kind of shows you that it was very popular in the 70s. It kind of died throughout the 80s. And starting in the 90s, it picked up and then died a little bit again, and then started to pick up in the early 2000s where it is today. And so it's something that has been very popular in Congress, and we've been trying to get the system there. If you notice, we've moved from a all private to a public option has been created with Obama, and that is a part way there, but hasn't taken us all the way to single payer yet. So here are some current bills that get discussed in politics, and so you got to be very, very careful what is and wasn't covered. Medicare-For-All is the topic, and so if it is not Medicare-For-All, it is not the topic. So if you see a card about Medicare for America, choose Medicare Act, Medicare X, the Medicaid option, public option, all payer systems, anything like that, or some sort of person's own magical creation of their own ideal single payer system. That is not the resolution. The resolution is a specific bill from 2019 that is either in the House or Senate, and so it needs to be Medicare for all. If it is not that, it is going to be very, very different, which means the links are going to be different. They're not going to apply. And so you need to catch people that do it wrong, and you need to make sure you or yourself not doing your research wrong. So what is Medicare for all? So Medicare for all, two bills, as I said, a Senate and a House bill. They're very much the same, but there are some differences and some similarities. So let's start with the basics. The introductory paragraph of each bill. The Senate bill says they establish a universal Medicare system, whereas the House actually says they establish a Medicare for all program. Now, don't be tricked thinking, okay, that means the topic's clearly the House topic. No, both bills are actually named Medicare for all, so both bills could be the ones that pass, or maybe would actually pass as some combination of the two. Because if you remember, when a bill becomes a law, if there's a difference between the House and Senate version, they first have to go to a committee where they fix any differences, create a uniform version, and then go back to both, and they have to both pass both, again, this House and Senate, before they go on to the president. And so they basically do the same thing, but the important thing you should know is that it's establishing a national health insurance program. It is single-payer system, and they go through all the following rules for it. And here's the link from it, and if you want to find, if you find an article talking about, Medicare for all does include this or does include this. These are bills. They've been in there for a long time. They might be talking about a different bill. It might be a bill that's been amended and it's been added stuff to it. So maybe when the person talked about it, the bill didn't include that as part of the services. And now afterwards, they did. After committee, they added it. And so it's usually helpful to have the exact text of the bill and know where all these arguments are deriving from this text of the bill. What does it basically do? What is a national health insurance program? So right now, when you have to do the premiums, the copay, all that stuff you're paying, monthly just to get health insurance, it's going to the insurance companies. Insurance companies take all this money. They then negotiate with the hospitals and say, here's what we will pay per procedure. And so you give all this money to an insurance company, and an insurance company gives some of that money to a provider. The goal of single payer is to just eliminate the insurance company, to add the government to take over, and the government, you give the money to the government, and the government pays the provider. An analogy would be as if, you had someone cutting your lawn, but you couldn't hire them to cut your lawn. You had to find a third-party official service that you had to pay, $20, and then they paid someone $10 to cut your lawn. You're using the government to cut them out of the picture, to say, let's stop paying that random person $20 just so they can keep $10 and do nothing. I'm going to just pay the person directly, or as close to direct as possible, that $10, or give through the government, which they'll again give to the $10. Now, you can't just say eliminate the government and let's just pay individual hospital people, Because remember, if you have a heart attack or something and you don't have insurance, they're still covering you, and someone has to foot that bill. And if it's not the government, it's going to be everyone else they're charging. And so, and it's, you don't want to get sick and then have to search online. Okay, these are the following sicknesses I have. Do I go to hospital A, B, C, or D? You kind of want some level of uniformity and not having to spend hours of your life figuring out which one to go to before you go to, and maybe you die before that, or at least get sicker. So what are some similarities between the two? What are some key elements? First of all, eligibility. One thing that makes this radical, this comes from Section 102, is that applies to all U.S. residents, not just citizens. So people who are U.S. residents, meaning they might be here living, but they are not necessarily going to be legal immigrants. They might not be completely through the process yet. They are covered by health care. And so it is something that is new in this bill and people talk about against, that we shouldn't cover people who are legal immigrants. But if you think about it, if your neighbor gets sick and it's not just because you're American and then they're not originally from America, them getting sick doesn't mean they can't get you sick. That's not how pathogens work, and so it makes sense to loop everyone in the country kind of together. And so I think this is a kind of average argument that'll be discussed some, but not terribly a lot. Abortion is one I think that will be talked about. So in Section 104, this act explicitly covers abortion. So right now, abortion is constitutional in the country, which means states can't necessarily say you can't do it, but they don't have to fund it. And the federal government has an explicit law that says no federal funding can go to cover abortion. So if you want an abortion, you got to pay it out of pocket, basically, is what's happening. And so what this does is this says now abortion is completely covered. You can go and have the federal government deal with issues of terminating pregnancy for the pros and cons of that reason. So I think this is going to be a very popular argument because it is a very partisan topic, but it is something that is a little bit smaller portion of the overall bill. Exclusivity. So one thing that these bills do is they basically ban duplicative private insurance. And so if the government is taking completely over the role of healthcare. Now, things that aren't covered by the government, if it's not an essential procedure, it's a cosmetic procedure, things like that, there could still be the role of private insurance. You could have supplemental private insurance. But that is a very small amount of overall insurance, which means overall private insurance is going to go away, and this is going to be a very, very big argument to talk about the pros and cons of this. What does it cover? Now, healthcare, this explicitly covers both all of healthcare, emergencies, dental, vision, hearing, etc. And so it's a little bit more broad than traditional single-payer programs that might have just said healthcare and some emergencies. This also does dental, vision, hearing as well. So this is an argument that's helpful for a lot of your debates because you need to know what it exactly covers. Cost sharing. Do you have to pay any deductibles? Do you have to pay any copay? Do you have a limit? Do you have to pay any premiums? The answer to this is it pretty much eliminates most to all, depending on the bill you pick, of these out-of-pocket payments. And so if it is an essential medical service and it is not supplemental, these bills cover 100% of it. You don't have to pay a dime. And so that is something that is very important of this, is that eliminates all those little bitty costs you would be paying. Long-term care, they both provide long-term care. So if you have disability or if you're old and you're really old and you need to go into a facility where someone looks over you in a managed sense, this is something that is 100% covered through healthcare. And so as well through these bills. So let's talk about some differences between the bills. So first of all, that if you note that the bills aren't 100% the same. Here are some key differences. It's not every difference, but here are the big ones that I kind of picked up on. One, when they first start. The Senate starts 4 years from passage. The House starts 2 years from passage. So neither happened, before Trump, neither happens before re-election. Neither happens before next year. It's all something that won't happen for a few years, but it might pass now and get everyone prepared. However, there's an exception. If you are a child, then it's going to happen within 1 year. And if you are an older person and it's the Senate bill, not the House bill, then it'll also happen in 1 year. And so those people get phased in a little bit faster. What about prescription drugs? So for prescription drugs, if it's the House bill, they're covering 100% of it. All prescription drugs are covered. The Senate bill doesn't do that much. The Senate bill covers most prescription drugs if they are generic. And there might be some cost sharing. You might have to pay some deductibles, some copay. But for the most part, if the generic, the Senate will cover it. If it's a name brand, they probably won't, and you're going to have to pay more money for that prescription brand. What about whether this is a type of procedure that's covered? Is it experimental? Is it non-medical? Is it something that's not the normal way they suggest to do things? So they're a little bit different, but a little bit the same. The Senate basically says the DHHS, the Department of Health and something safety, basically healthcare department. The secretary gets to Department of Human Services, something. Sorry. Anyway, basically the secretary, the person in charge of the department, gets to set the rules. Congress says, this is complicated. We don't know what is and isn't covered. We're not doctors. We'll just let the person in charge of the government do it, the government agency. The House does that, but they have a little bit more. They want to say, we're going to build in a few extra stuff. And so generally the secretary gets to decide, but the secretary also needs to make sure that there's an ability for the physician to override these standard procedures and to justify doing something experimental if the physician thinks it's in their best interest. And so does this override provision never exist in the Senate? No, the secretary could say that's a great idea and just do it themselves. It's just the House has it already built into it, and it's not super specific anyway in the House, so it's still going to have to be talked about by the secretary no matter what. And so while this seems different, it's probably not as different as you think it will be. Compulsory licensing is one that is a little bit different. And so compulsory licensing says basically when the government takes over, they still have to pay pharmaceutical companies. Now, how much is the government going to pay? They have to negotiate. They have to basically sit down and say, okay, we're going to pay this amount for this pill. Is that good for you? And if they say higher, the government either says yes, or the government goes and finds someone else to do it. That's how traditional negotiations work. Now, the Senate, basically what happens if the pharmaceutical company says no? You must pay really, really high, or I'm never selling it to you and I'd rather let it burn. And the Senate, the pharmaceutical company has that right. They can hold out. They can say, I'm going to wait for a very, very high amount, and if the government doesn't pay, then the government doesn't pay, and they can just have people die. The House has something called compulsory licensing, that if negotiations fail, the government decides, I don't want to pay that amount. They can just take your formula, produce it themselves in a factory, and give it out themselves and cut you completely out of the equation. And the only thing you can do is go to court, and then the court will say, here's the amount that is reasonable for them to pay you. And so it's basically like the court will decide what to pay. And it's not going to be the amount the pharmaceutical company wants, and it might be much closer to what the government's offering. And so that's one big difference, is that in the Senate, prices might not go down as much, but in the House, pharmaceutical prices are going to go crash because the government is going to have a lot more power to say, we're paying a low amount, and if you say no, we can always undercut you and do it ourselves. Whereas they can't do that in the Senate. So beyond this, let's talk about some public information, some public opinion. Very important to this is the role of public opinion. That, this is a topic that has a lot of studies about it. And with all of these studies, that one thing that's cool about it is there's been a lot of, high quality, they do mini debates in front of people in the public and say, what are the good arguments, what are the bad arguments? Which means these studies are like basically studies of debate rounds, studies of judges, which in public forum is super, super awesome for you because it lets you know some biases and things to talk about. First of all, generally the public's more in favor of Medicare-For-All than against. So thinking at pro versus con bias, there is a pro bias. And it's been that way for at least a few years. And I have older graphs I can pull up that say when it flipped, what used to be when they were against single payer. But for the relatively last few years, the public has generally been in favor of it. Beyond that, just because the public's in favor or against it doesn't mean that's, politically who's in favor of it. So it's definitely more the Democrats and independents. And if you were a Republican, you're much more likely to be against Medicare for All. Seems pretty obvious, but just to make sure these are actual studies that have backed out based on, surveys they've done. What about the reasons why people are against it? So for people who are against it, the primary reason is they don't want the government involved. The second reason is it costs too much. The third is we don't have choice. We don't have innovation. We don't have competition. What about people who favor it? The primary reason is universal coverage. And the secondary reason is more to make costs more affordable. And so these are the most popular reasons people first think of, but that doesn't mean they're the most strategic reason. What about public opinion polls? Which ones that actually persuade? So they start by saying Medicare for all to someone, and then they say, explaining what actually Medicare for all does. When they explain that it guarantees health insurance is a right, it is a lot popular amongst people. When they talk about eliminating costs, premiums, and copay and all that, also very popular. However, when they talk about having to eliminate private health insurance, not popular because people might like their current insurance. They might be afraid of getting a bad one because everyone else has a bad one and maybe the government's one will be a bad one. Also, the idea they're going to have to pay more taxes. People don't like that because how are we going to fund this? What about that could hurt the current Medicare program because the budget could be limited? Or there could be more delays, waiting times, quality of care, things like that could happen. All of those make people like it a lot less. And it kind of shows you the things that are a little bit more popular with people versus less popular with people. How much does it cost the federal government? So there's a bunch of studies. I kind of listed a few. You can kind of click each link. But the important thing to think about it is, a few trillion per year. It is not a small amount. It is a very large amount of the overall federal budget. Anywhere from double the budget or, 75% greater budget is what people are saying might be needed. And so it costs a lot of money to do this up front, to pay for it through the federal government. And so is that necessarily the full picture? On the other side, some people are going to say, that's only one side of the equation. And that equation's being kind of biased because the insurance company has a reason to promote the narrative that it costs too much to let the government do it. Just let us do it. And the reason why is insurance isn't free anyway. And so even though it's going to cost the government money, it already costs people money now having to go through private insurance. And so right now, if you had to pay a certain amount of money on private insurance, if you could take that money, just pay it on more taxes and have the same or better health care, meaning you have more coverage for less money from the federal government, then it's an overall net cost savings. And that's kind of explained in this graph. That, yes, you're right, it's going to cost a lot of money now, and while switching to paying the federal government is going to mean the federal government's going to have to pay a bunch, we're going to have to increase taxes. Those tax increases are going to be offset because individually you can pay those taxes because you have to pay less to healthcare because you no longer have to pay private insurance. So beyond that basic cost argument, let's talk about some of the reasons for the cost. Cost is a very complicated, particularly economy is a very complicated argument. And so let's talk about some of the pro and con arguments on both sides of the equation. First thing to talk about is administrative costs. So administrative costs basically say right now when a hospital has to negotiate different rates for every single insurance company, it takes a lot of time. And when someone gets sick and they have to bill and make sure the billing is specific to those rates for that specific insurance company, it takes a lot of people you have to hire and administrative excess. Whereas if it's just one government doing it, then that government just has to negotiate it once. They don't have to have 100 different negotiations, just once for that procedure. And so that's the idea. It could save money administratively. On the flip side, some people could say it's going to cost money because the government is, corrupt, inefficient, bloated. They always think they're better, but they're just not as good. So no matter how bad the private market is, the government is worse. And so that is an argument on the other side of it. Rising healthcare cost is another one of the reasons. And so one of the pro arguments is that healthcare costs are continuously increasing, and they're going to continue to increase until we get them under control. And that the only way we can get them under control is by having the government take over and negotiate fixed prices. Now, the con might say, sure, but the government's going to end up with a higher price, or it's going to even get higher costs. And so it kind of goes both ways, but is more of a pro-biased argument for sure. Financing, how do you pay for this? Is it going to be premiums per person? Is it going to be through payroll taxes? Is it going to be general taxes? Is it going to be just deficit spending? Is it meaning the government just putting it on the credit card and never actually getting the money for it? Or is it going to trade off from other things? Is it going to come from the military, from other things like education? How are we going to actually pay for it? And so there are some pro and con arguments on both sides, but a lot of the con is going to say if you're spending money we don't have, then that's going to trade off from other important things, or it's going to have to raise taxes, which is going to hurt economic growth in the long run. Whereas the pro might be saying stuff like, yeah, the taxes are a little bit bad, but it's offset by other things. Or they might say we pay through deficits and deficit spending is good. And we'll talk about that in a second. Job lock. This is a little bit more of a minor argument that says people won't switch jobs right now because they like their health insurance and they don't want to try a different carrier. Because it takes time and they get used to something. And so we like people switching jobs because that means you can always go to the best job for you. You don't want to get trapped in a job you're not good at or efficient at or getting paid for what you should be. And so this is a kind of economy argument, but it's a little bit smaller about job efficiency. There's also aggregate demand slack. And so this is generally the idea that government spending is good, specifically in situations when the private market isn't spending. So when the private market is not building anything and people are just idle and doing nothing, the government should step in and fill those gaps and just do stuff that the private market is not doing. And so in times of economic crisis like now, when a lot of people are unemployed or underemployed, an argument is had that the government should offer jobs, the government should spend money so that people can themselves, they get a job, they get money, they put it back in the economy, and it helps restart the economy. And so this is the deficit spending good argument. It is a popular argument on the topic. It'll be a good answer to the tax argument on the pro. Whereas on the con, there are some studies that say if you do normal taxes, the cost savings are true, but if you fund it through deficit spending, it actually hurts our economy in the long run. And so you do have arguments that go both sides, and this is an important argument. International competitiveness, this is a smaller argument, but the argument basically is if we hurt our doctors and our healthcare in any way, people will just go to other countries to get healthcare. And so, or the doctors will go to other countries to work. And so if we cap the amount we're paying a doctor because we're paying them a fixed fee, or we cap the amount we're paying the company that's developing it, they'll just go to a different country and develop it. And sell it to other countries. And so this argument is a little bit less because right now we have the highest cost. And so if they're selling it to anyone else, they're selling it low anyway. Some of the stuff's a little bit more specific, like the upper middle class are the ones going to other countries from the United States to get better health care that they can't afford in the United States, but they can afford to go abroad. The death spiral is very similar to rising healthcare costs. It basically says that healthcare costs are rising because more people are dying, which means they're older and older people, which means those costs to keep them alive are greater and greater, which means as society has a longer lifespan, the healthcare costs are just going to go through the roof inevitably. And so even if we were, controlling the cost for the negotiations, the very fact people are getting older, and when they get older, the healthcare costs are a lot higher because we can spend a lot of money just to add one more year of your life, and that will happen. And so that caused rising costs. New industries, if we don't have healthcare, where do these people go? Is it biotech? Is it agriculture? Is it technology? Those could be good things. Conversely, it could be bad things. What's the industry that's going to die? It's pharmaceutical industry at the very bottom. That is one that if we negotiate very, very low prices, which helps us save money, the pharmaceutical company doesn't like that, and they might go out of business. They might develop less vaccines. They might put less money toward research and development because they fear that they're going to get paid less for the development. Why put all this money to develop a drug if we only make half of what it costs for us to develop it? And so the argument is that because of lower prices, because of universal health care, the pharmaceutical industry will collapse. They will have less innovation, which means, or it can hurt the overall economy because they affect that level of economy. It can even be worse with compulsory licensing. So we give them a low amount and the court lowballs them and gives them even lower amount. That could be very bad for them. Employment can go both ways. It could be about increasing new jobs or higher wages, depending upon how the negotiations go and that type of thing. Private insurance companies, something that's more of a con argument for sure. They're likely going to go bankrupt or be bought out by the federal government because they won't really exist, but in a supplemental fashion. And so that's going to be a big con one too. This entire asset-oriented industry of private insurance will go under immediately, which is going to cause a quick rush on the market, which is going to cause a very short-term economic crunch. Beyond that, let's talk a little bit about methodology. So with methodology, there's one article that everyone's going to really like and talk about on the Pro, at least for this topic. It's this 22 studies card that says we looked at 22 studies and we found that most of them liked healthcare. They thought it saved money over time. And they kind of went through the various things they save money on and said there's agreement amongst these 22 authors that it saves money overall. And so this is the study. It's a little bit more complicated than that. You should read the study. You should know the study. But let's talk generally about how you should approach these studies. So when you hear a study, you should first think who studied it and what healthcare system do they have. Is this a study of the U.S. versus the world? If it's EU, they might have different cultural differences than the United States, which means it might affect the level of health in the society. If not everyone's eating fast food all the time, there's less obesity, which means that, of course, they're going to have lower healthcare costs. There's also the question of whether the individual states. So if it's the U.S. versus some U.S. states that have more Medicare-For-All like stuff, like California, then you have to see what exactly it is that state had. What was covered, how was paid, eligibility of the people in it, were there copays, deductibles, all that stuff. Because if it's not the exact same as what's being proposed, then it might have different effects. Or a lot of them are just going to be guesses. It's going to be some one sentence of someone just guessing what they think their ideal version of it would cost or do. Also, what are they studying? Is it actually the Medicare-For-All Act of 2019? Or is it just someone talking about Medicare generally, or single payer, or things like the public option or some sort of split option? Or just healthcare in general, or government healthcare in general? If the more general it gets, the less likely it applies specifically to the topic. If it's an actual study, what does it cover? What is the sample size of the study? Are they using simple statistics? Is there an actual regression model? If they do use a regression model, what are all the control variables they're accounting for? What other biases from the study did they account for? Is the end result statistically significant? Did they employ any type of cross-validation or machine learning to help improve their accuracy of their models? Meta-analysis is sort of a fancy term of I take all of these different regressions and I combine them into one super regression. And so here's kind of what the graph version of it looks like. You have all these little studies and you have ranges of their results based upon how accurate that study is and how it was designed and what their conclusion was from their data. So the pro of this is you can get more consensus. You have more studies. You might have better accuracy because, one study could be bad, but 19 could be good. The con of this is sometimes the group is wrong. Maybe it's just that one person is right because the one person was right and everyone else was wrong. Or one good study that has really, really good procedures and methodology could be worth 1,000 bad studies. Alternatively, a good version of meta-analysis has to account for different methods and biases of each study. In order to make cross comparisons, they have to be universalizable in some way, or at least generalizable in some way. So if you note on the previous one, we talked about the good old Chi card, the last sentence, all the studies were different, so we couldn't actually do meta-analysis. So this is kind of just simple statistics, literature survey. And so it's not necessarily a great study for healthcare, but it's going to be a very popular one people will talk about. What about impact calculus? What's the important impact calculus you have to make? And so for impact calculus, the important thing you have to make is simple. It needs to be about magnitude, probability, time frame, causality. Magnitude will be more about economic growth / well-being frameworks. We should value everything in terms of the economy, and we'll have a card for that. Probability should be more about quantitative numbers because that's what matters in PF. That because you have numbers, because you have studies, they're more true. Time frame is, if you're talking about economy, then the economy is very finicky right now. It's on the brink. Your impact could be very fast. As soon as the plan get passed, the insurance company could go under the next night. And so it could be a very quick impact. Finally, causality. So economic decline could be the root of all their impacts. If we have an economic decline, it means pandemics could be more likely. It could mean that there's going to be more government coercion in the future. It could mean that all sorts of people are more likely to die from health issues because they have less money. There's all sorts of stuff that could happen because of economic decline. It could mean there's less money even paid for Medicare. And so this is something that's very, very important to focus on. Out of all of these, I think the first three will kind of speak for themselves. But the fourth one, you're going to have to spend time on whatever your opponent's contention is. You're going to have to talk about how economic decline actually causes that more. Let's talk quickly about some of these other contentions. I didn't go through everyone. I kind of just went through what I think is the most important, which is the economy. But there's a little bit for everything, and there are cards in our research file you can look at. Abortion. The topic allows abortion, says abortion is covered by the government. There are people that are going to say abortion is evil. That is a con argument you got to answer. People might say it's a great thing for women's choice. That's a pro argument you have to answer. Bioterror. This is the argument that there could be a biological attack on the United States by a terrorist. The only way to best prevent those attacks is if we have a very robust preventative system. And that preventative system is something that can happen through healthcare. If we don't have healthcare and everyone doesn't have healthcare, there's people who are uninsured. That's more people who can get sick that we can't test, that we don't know are sick, and spreads the original biocontaminant out across society. And so the best prevention is 100% universal coverage, and that only happens through universal healthcare. Beyond that is circumvention. So there are arguments to talk about why the government doesn't solve. That their ideas make sense in theory, but in reality it won't work. Either, Trump's going to win an election, he's going to screw it up. Or even if it's not screwed up, it requires the government to negotiate, and they're bad negotiators. Or the government's corrupt, and so they're going to get paid off to negotiate poorly. Or the government's not really good at enforcing these things. Or the courts might try to strike it down and say it's unconstitutional. All these things are something that I think can happen in the world of circumvention, which is a good con argument. Diseases, pandemics is a great pro and con argument. For pro, generally the argument is more prevention-oriented, that if we had universal health care, we would have a better response to pandemics like COVID. Whether it's better, faster vaccine, better coverage, better enforcement of rules, things like that would happen more with universal coverage. Elections is also a common argument, that if this bill passed, this is a lightning rod, so it might immediately mean Trump wins or loses the election. And so an argument to be had that makes that talking about your contention all about whether Trump is good or bad, purely because healthcare could be the way to get Trump to win or to get Trump to lose. Federalism. So healthcare is traditionally one of those things that's done by the states or local government. It is not done by the federal government, like education. And so having the federal government take over healthcare might have slight constitutional issues. It might be an encroachment on state rights. And some people might say that's bad. Healthcare quality, and so there's a lot of little arguments here. There's arguments about doctors' trust being increased or decreased with the system, their pay, wait times, medical tourism, all little bitty stuff about whether the healthcare quality goes up or down as a result of universal healthcare. And so while you should know a little bit of everyone, you don't need to be an expert of anyone because they're not all super big or quantitative. Immigration, remember, it covers non-documented residents, so an argument could be had that this argument causes more illegal immigration, and that would be good or bad depending on how you take it. Inequality is another huge one, that there are distributional effects of healthcare. Not everyone gets healthcare equally. Private markets might be more discriminatory based on race, gender, income. And so having a universal system might be fair for everyone because everyone gets the same baseline rather than just the rich getting the good healthcare and everyone else getting the bad healthcare. Innovation pharmacy industry. And so this is the argument, primarily a con argument, that if you lower prices, they're going to stop researching and developing, which means less new drugs, which means no new cancer cure or no new COVID cure. And so things like that are something affected by healthcare. Military readiness is the last one. This is more of a tiny one. That there's cards that say health insurance is the primary one good reason why people join the military is because they get free health insurance in the military. And when they're deciding whether to have a job or not, it's a more universal system in the military, and statistically, health insurance helps improve recruitment in the military. And so basically there are a lot of tiny contentions. Should you worry about all these? Maybe just knowing what they're about, know your responses, but think primarily as how does economy outweigh these? How can you use your economy contention to get to these various internal links? Because if you're pro, you can be saying like the economy is inevitably going to collapse because of rising healthcare costs. We have to get it all under order through the government, through a public system, through a single payer system. If you're con, you could be saying the opposite, that the rising costs are okay. They're under check right now. But if we eliminate the insurance industry overnight, then there's going to be a huge crash in the stock market, which could cause a short-term crash that affects all sorts of other issues. And so winning the economy is my biggest suggestion, and knowing a little bit about all these issues is another suggestion. And so this is the basic beginning lecture on some of the key issues on the topic and some of the little tricks here or there so you know. But what you should be doing from here is now looking at our 300-page evidence set. Start going through, finding some cards you like for contentions you want, and start writing some cases, either pro or con cases. And start from there then thinking about what are the rebuttal blocks you need, what are the impact calculus you need. And so if you have any questions, feel free to ask. But for the most part, thank you for watching, and this is our introduction to the topic for September, October, Medicare for All for PF.